Hello, and welcome to our webcast. I'm Jamie Pennington with Moss Adams, and I'm getting us started for today's session, Medicare Regulatory Update 2024 IPPS Final Rule. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining. We're pleased to present our continuing professional education webcast series. Before we begin, please keep the following in mind. You can customize how you view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can adjust window size and placement or enter full screen mode using the controls at the top right of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons that relate to a different aspect of our session. You can download a PDF of today's slides from the Slide Deck and Handouts widget. You can ask questions by typing in the Q&A window and clicking Submit. We'll do our best to answer all questions or follow up via email. If you experience technical difficulty, refresh your browser by hitting the F5 key. Today's session offers 1 CPE credit. To receive credit, you must meet the National Association of State Boards of Accountancy requirements. You must attend at least 50 minutes of the session and respond to at least 75% of polling questions. To participate in the polls, please check the button next to your answer within the slide window and click Submit. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget and download your CPE certificate. Don't worry if you can't download your CPE certificate today. We'll email you a copy in 2 weeks. If attending this webcast in a group, you must complete our group CPE attendance sheet, available in our Slide Deck and Handouts widget to receive credit. Please have all group members sign it and send only 1 sheet per group. CPE credit can only be awarded to participants registered as themselves and isn't available for participants who view the on-demand version. This presentation is not legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
And now I would like to introduce today's presenters from Moss Adams, Eric Lucas, Managing Director, Glenn Bunting, Managing Director, and Jonathan Mason, Director. Their bios and contact information are located in your webcast console for your reference. And now I'd like to turn the floor over to Eric to get the presentation started. Eric?
Thank you, Jamie. Okay, today on the agenda for the final 2024 IPPS rule, we're going to talk about the change to the payment rates, the updates to the MSDRGs, spend a little bit of time on the wage index, which is a big change in this upcoming year, as is the Medicare DSH uncompensated care. We'll talk briefly about the changes to GME and the Nursing Allied Health Program, spend some time talking about quality programs and the health equity issues that we're seeing throughout these items, and then we'll have some housekeeping at the end. So I'm going to go ahead and get us started. Let's talk first about the payment rate changes. Oh, let's actually first take a poll. The first poll here, we have Medicaid redeterminations have received significant attention in the media over the last several weeks. How concerned is your organization regarding the impact Medicaid redeterminations will have on DSH payments, payer mix, and/or revenue cycle resources? A, major concern, B, slight concern, C, not concerned, or D, I don't know. We'll take a couple seconds to fill that out, and then we'll get going.
Just a reminder to respond, please click the button or the answer that you choose and hit Submit. If you can't see the answer choices, please enlarge your slide viewing area. We'll give it a few more seconds. It looks like our responses are starting to flow. So here are your results.
Well, that's exactly what I would expect. We did a webcast and a number of presentations on the end of the public health emergency, and the questions that keep coming up over and over again relate specifically to the redeterminations, how that's affecting DISH, potentially impacting 340B. It's going to require quite a bit of resources to make sure that a lot of these patients get back into the Medicaid program effectively. But there's simply just a lot of uncertainty out there. So this is pretty consistent with what we're seeing elsewhere. Okay, so we'll talk a little bit more about DISH later. But first, let's talk about the change to the operating payment rate. They settled on an increase of 3.1%. That is up from the proposed increase, which was 2.8%, but still quite far below last year's increase of 4.3%. The 3.3% is or 3.1% is 3.3% market basket update with a small productivity cut here. The one thing I would point out that is missing here that we've had for the last number of years is there's no longer a American Tax Relief Act adjustment that we've been seeing since 2014 now. Which related to overpayments that occurred in 2010 to 2012. They are now have completed the recoupment and restoration of the rate back to where it was supposed to be after much congressional activity to slow that process down. But it is now complete, and we won't see that adjustment in the future rate setting. Just for comparison purposes, that was a 0.5% increase over the last 5 years. So even with that, I wanted to point out that while we're seeing a $2.2 billion increase in payments as it relates to that increase, we're still seeing some significant declines. We'll spend a little bit of time later in the presentation talking about this first one, which is to DISH payments, specifically to uncompensated care payments and how that pool has declined. That is significantly up from what was proposed in the earlier this year. There's also a small decline in medical technology payments we'll talk briefly about. But the one concern that seems to be expressed over and over again here is that despite the 3.1% increase, inflation continues to scale, especially within hospitals, at a higher pace. And so the concern is how hospitals are able to keep up when the rates clearly are not. So to talk about 3.1%, there's still the limitation that hospitals will need to submit quality data and be meaningful users in order to get the entire increase here. There continues to be significant penalties here. And as you can see in that last column, if a provider does not submit quality data, is not a meaningful user at this point, we're looking at actually a rate decline. So let's just really quickly talk about what we do with this rate. So we have an overall rate of $6,497. That needs to be split up between a labor and non-labor portion. Glenn's going to talk in a little bit later in this presentation about specifically the wage index portion or the labor portion of this. But I wanted to point out that in this particular case, we're going to take that rate, we're going to split it up between the labor and non-labor, and without spending too much time talking about the complications related to DISH or IME add-ons, we apply the MSDRG weight to come up with our ultimate payment. So splitting that up, you can see the labor and non-labor pieces there in connection with the capital payment that's also listed. The big increases here really relate to the capital side. But the other thing to point out here is that hospitals that have wage indexes at 1.0 will see a smaller portion of their overall rate being applied a wage index to the labor section of that. So labor is higher on the wage index is above 1 and lower on those at 1 or below. So once that comes in, everything gets a little bit more complicated. And over the years, this list has continued to grow and grow to get to our current rate setting. For every one of these line items, in most cases, is adding a budget neutrality factor to ensure that the program does not overspend based on another provision somewhere else in the payment process. And rather than going through every one of these things, I really just wanted to point out that when we talk about, say, the wage index sections, there's going to be a wage index budget neutrality factor that's going to offset any changes that had to be made for a specific wage index provision. But the other one I wanted to point out is the operating outlier factor. This isn't new. This has always been there. A portion of the rate is adjusted out to reflect the additional payments needed for outlier payments, which are targeted at 5.1% annually, but is a projection. They can never fully get that perfect. So to go to outliers in the current year, we're seeing another very big increase in the threshold to try to land at that 5.1% target. In FY22, they actually overspent at 6.8%. And we saw it last year, one of the biggest increases to the threshold in a number of years, where it went up 25%, up to $38,859. Now, in the current year, we're seeing another fairly big increase of 10%. Now, this is coming after CMS has identified a change to their methodology in calculating the outlier threshold. And the one thing that they've pointed out is if they had not made this change, the threshold would actually be significantly higher than this. And that relates to how they adjust for COVID within the cases. So to point out, the outlier threshold continues to grow. It definitely needs to be identified and modeled in your particular providers. So let's talk about the changes to MSDRG. The one thing that I would point out is in all cases, the MSDRG proposals were finalized as is. So they made the changes as proposed to how they were going to calculate the MSDRG weights. They're no longer adjusting for COVID-19 hospitalizations in there. The 22 MedPAR claims are being used along with the 21 cost report to develop that rate. As proposed, there's 15 new MSDRGs and 16 MSDRGs are expiring. To get an understanding of how much movement has occurred in the MSDRGs, 21% of the MSDRGs are changing up or down by 5 to 10%. 6% are exceeding 10% positive. But I also want to point out last year, CMS finalized a cap so that the DRG weight could never decline more than 10%. Currently, there are 36 MSDRGs that hit that cap. So those could continue to see further decline in future years. These are the largest relative weight gains in the DRGs. There's not much change except for the final one. MSDRG 592 was not on this list before, though it was hovering at just below it. Before it was DRG 583, disorders of personality and impulse control, which has dropped a couple points down from here, but still quite a big gainer. The biggest change to how DRGs were calculated was to MSDRG 18 for CAR-T-cell and other immunotherapies. The issue here is that a number of these cases are actually provided at low or no cost. And so CMS didn't want to include those particular cases within their calculation of the DRG weights. Before they were using a proxy to identify those and pull those out. But As they said in the proposed regulations, they do believe that they can identify this through the coding that's currently occurring on these cases. And so they've abandoned the use of the proxy and are able to identify these particular cases and adjust accordingly. So a few of the changes that we've seen occurring, they're reassigning 166 through 168 MSDRG to 173. They're reassigning 222 to 227 to 275 to 277, but they're also adding those to the post-acute care transfer list. And then they've added MSDRG 212. And then I talked briefly about actually that was the proposed regs, the end of the COVID-19 add-on payment, which is expiring in the current year. So we have only about a month left of that particular add-on, and then it will expire. CMS also made note that they are looking at the complication comorbidity and major complication comorbidities to determine if those are currently identifying proper resource usage. That analysis will continue. So as they continue to do that, they're making no changes, except they are making a change to the severity level for cases of where 3 particular homeless codes are used in the ICD-10. We'll talk a little bit more about this later on, but this is the only material change where those who have that homelessness code will move into a higher DRG weight because of the additional resources needed because of now being identified as a complication of comorbidity. The new technology add-on, I mentioned earlier, they've made a change to the process of how a technology will be identified for inclusion on this list in the future. That has been finalized. This declined, a lot of this decline in the payments they're anticipating for the NTAP technologies is essentially due to the fact that a number of technologies are rolling off. This is for a limited time while these processes are being absorbed into the DRG. And as a result, a number of them are being rolled off in the current year. There's 10 new NTAPs being identified under the traditional pathway and 12 under the alternative pathway. Only 11 are staying on, but of the 15 that are dropping off, you're seeing about 500 million in decline in payment here. So now let's move over to wage index with Glenn Bunting.
All right, thank you, Eric, and good day, everyone. As we move into the wage index section of the presentation, for starters on this slide, we are providing you with an illustration from our friends at MedPAC showing how the Medicare wage index factor is incorporated into the Medicare payment calculation. So as Eric mentioned, we start with the operating base payment rate. This is also known in common speak as the labor component. And from here, the wage index geographic factor is multiplied to the operating base payment. There are 2 paths for payment, depending upon whether your specific wage index factor is greater than 1 or equal to and less than 1. If your wage index factor is greater than 1, the resulting calculation is multiplied by 67.6% as shown on the slide. And if it's equal to or less than 1, the multiplication is by 62%. From here, the resulting calculation, whichever way it falls, is added to the non-labor component, and you arrive at an adjusted operating base payment before case mix adjustments are applied. The MS-DRG case weight, which corresponds to the patient's diagnosis and the severity of that diagnosis, is then multiplied to arrive at an adjusted operating base payment rate. If we circle back to the left on the screen here, I'll note that the wage index factor is a multiplier in this calculation. And so the takeaway from this is that the greater the wage index factor, the greater the Medicare payment. Also, as a side note, there's a Medicare capital payment calculation, which is very similar to what you see here, but it is without any distinction for labor and non-labor components. One of the more controversial issues in wage index circles was CMS's application of the low wage index hospital policy. Let me kind of outline what the issue is. Under the current system, it allows hospitals in states with significantly higher wage indexes to maintain and improve their favorable position in the current system by setting higher than market value wages for their employees. Low wage index states, they cannot afford to pay wages that would allow their hospitals to climb back toward the median wage index. So over time, this condition increases the gap between the wage indexes of the high and low wage states to a much larger degree than what the wage index was initially designed to address. So CMS has recognized this problem, and back in the 2020 final rule, they initiated a proposal, and then they adopted a temporary increase to wage index values for the low wage hospitals. And this was intended to last for a 4-year period from fiscal year 2020 through 2023. And here we are in 2024, the final rule, and CMS is going to continue this policy. They state the following: given our current lack of sufficient data with which to evaluate the low wage index hospital policy, we believe it is necessary to wait until we have usable data from additional fiscal years before making any decision to modify or discontinue the policy. So what was their solution starting in 2020 and moving forward all these years? And the solution is to increase the payment for the hospitals that are in the bottom 25th percent quartile. And in federal fiscal year 2024, in this final rule, the 25th percentile wage index value across all hospitals is 0.8667. So what that means is if you are at that value or lower, you will get a bump upward in your wage index value by CMS. CMS states the intent of this proposal is to increase the accuracy of the wage index as a technical adjustment and to not use the wage index as a policy tool. I'll let others decide if that's an accurate statement or not, but that is what they have said. As in the past years, CMS is proposing to fund these adjustments by making a budget neutrality adjustment to the standardized amount. So specifically, negative adjustments are applied to the national standardized amount for all hospitals, including those hospitals that benefit from the increase, and that's intended to offset the cost of the increase. Just some facts here from fiscal year 2020 through 2023. That payment reduction ranged roughly right around a fifth of 1%, or 0.20. In fiscal year 2024, in this final rule, there's a significant increase upward. It's a payment reduction of just slightly under 0.226. So it's actually 0.2598. That's the payment reduction. The interesting thing with this CMS low wage index policy is it has brought forth a few legal challenges by a couple of hospitals, as you can see on the bottom of the slide. We have Bridgeport and Kauai Delta. They have prevailed on this. They basically brought the challenge stating that the budget neutrality adjustment payment reduction was unlawful. In district court, both hospitals prevailed, and the decision was that CMS's position was inconsistent with the Medicare program's wage index statute, and they also found that it can't be adopted it can't be adopted or I should say accepted under HHS's exceptions and adjustments authority. It just doesn't meet that standard. CMS is appealing these decisions. The appellate briefing is complete, but arguments are not yet scheduled. So, we'll have to see, just kind of keep our eye on what will happen here with this low wage index policy and how it'll develop. Let's see here. I think, Jamie, we're at our second polling question, so I'll turn it over to you.
Perfect. Our second polling question is, are you actively affected by the low wage index policy? And your answer choices are A, yes, B, no, and C, unsure. Just a reminder, you do have the option to submit questions for the presenters in your Q&A window. We do have quite a bit of content to cover today, so if we don't have time to respond during the webcast, we will follow up with you afterwards. And if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the four polling questions. There's still some answers coming through, so we'll give it another few seconds. And here are your results.
All right. The results are a little mixed here. I think if you want to get down to the factual answer, the answer really is yes, everybody is affected by this, because it becomes, at the end of the day, it becomes an adjustment made by CMS to decrease everybody's wage index amounts. But the fact that there's a lot of people that have answered unsure on this, it's not surprising to me. It's a complicated issue, and we're just all going to have to sit back and see how the chips fall on this from a legal standpoint, on the low wage index policy issue. I want to move forward to just wage index values. I kind of refer to this informally as a fun fact page. The final wage index values that are in the 2024 final rule, they come from cost reports that begin in federal fiscal year 2019. Actually, it's cost reports that begin on October 1st, 2019 and forward. So that's something to keep in mind. The method used to compute the 2024 wage index without occupational mix adjustment follows the same methodology that was used to also compute the wage indexes without occupational mix adjustment in the 2022 final rule. So not really much change there. Fun fact is the unadjusted national average hourly wage is $50.39. If you apply the occupational mix to that, it drops down to $50.34. Really not too much change from what we saw in the proposed rule a couple of months ago. Also to keep in mind, the data, the wage index data that has come out in this final rule for 2024 is actually based upon the calendar year 2019 occupational mix survey. I know a lot of you out there have just gone through the process of completing the occupational mix survey and submitting it. That will be used for the first time in next year's wage index values. There are approximately, I'll say almost 1,200 providers that are receiving a wage index payment that is based upon a core-based statistical area other than their own geographic core-based statistical area. That number has decreased a little bit from the proposed rule, where we saw the number was closer to 1,300. Today it's closer to 1,200. So there's more or less about 100 or so, maybe a little less than 100 providers that have rescinded their geographic reclass. Another thing it's not on the slide, but I want to make sure that folks out there remember this. It's an important reminder is that right now, the month of August, your it's wage index and occupational mix survey correction time for federal fiscal year 2025. Those corrections are due next week, and they need to be submitted no later than September 1st. If we go into the next slide, we have another big change, and this has to do with the rural wage index floor for the most part. What you can see, it's at the top. I've laid out here the existing methodology, which CMS uses the highest average hourly wage from the following calculations to achieve a rural floor wage index value. What they've done in this 2024 final rule is they have made a huge change, and that is to include reclassified rural or the reclassified urban hospitals to rural in the calculation of the rural floor for each state. So that's highlighted in red there, also underlined in terms of the reclassified rural hospitals. So why is this such a big deal? Well, if we go to the next slide, you can see the impacts that it's having. So I'll just start with the top line there with the state of California. Last year, their wage index value was 1.25. By making this change where you're including reclassified urban hospitals into the rural floor wage index calculation, in the proposed rule, that bumped that up to 1.50. And in the final rule, the final number is, actually closer to 1.52. What it also did was it makes certain geographic areas subject to the rural floor. You can't receive a wage index factor by law that is less than the rural floor. So last year, in the 2023 final rule, there were 9 in the state of California. And the proposed rule, that 9 bumped up to 19, and in the final rule, we got one more core-based statistical area that is subject to the rural floor for a final count of 20. And you can see, just looking at this slide, it's pretty powerful to see what this change has done. It's really kind of turned wage index for some areas kind of upside down. There's big benefits here for a lot of these states, but then there's also some states that will suffer from this. I think what it's really going to do, and this is just my opinion, is it's going to accelerate wage index reform. That generally, when you have big shifts like this and these big disparities from year to year, it kind of prompts Congress at a certain point to step in, take action, and CMS will give them several proposals in terms of how to make things a little more stable. But anyway, that's one of the bigger changes in the final rule for 2024. So with that, I will turn it over to Jonathan Mason, and he'll give us an update on Medicare DSH and uncompensated care.
All right. Well, thanks, Glenn. So I wanted to spend a few minutes covering the DSH and UC payment section. There was a significant drop in the size of the UC distribution between this year's rule and last year, as well as a pretty big drop in just even from the proposed to the final rule. So for the Factor 1 UC calculation, the DSH estimate actually begins with an anchor period, in this case, the 2020 Medicare DSH expenditures, which is then trended forward by a number of factors applied to the 2021 through the 2024 periods. And so the starting baseline total was $13.2 billion, and then trending that forward, the end result is $13.354 billion for 2024. And so I wanted to point out the last column on the far right are the totals from last year's final rule. So you can see the significant changes with some of the projections and how much lower these same years in this rule are compared to last year's rule. And so the figures for 2021 and 2022 are based on actual claims data. 2023 is based on preliminary data, and then the figures for 24 are obviously projections and assumptions. So I wanted to point out regarding that other column, it's actually titled other column. This does include a factor for the estimated changes in the Medicaid enrollment from the COVID-19 pandemic and the end of the public health emergency. And in all of this, CMS points out that their approach in calculating all of these totals is consistent with previous rulemaking cycles. And just like in prior years, the Office of the Actuary updated their projections using the most recent data that has been made available between the time of the proposed rule and the final rule. And so the net result is a 2024 DSH estimate of $13.354 billion. That's close to $300 million less than the proposed rule. So after removing the 25% empirically justified amount, the final rule factor one for 2024 is $10.015 billion. And that's a little bit more than it's $445 million, I guess I should say less than last year's total. So this chart just shows the factor one totals from the inception of ACA. You can see the steady increase from 14 to I believe its peak in 2020. And now you see the steady decline to our current total. So moving on to factor two, which is the factor calculating the change in the uninsured rate. And really this is where we saw the biggest and probably the most shocking change from the proposed rule. In the proposed rule, CMS calculated the percent of individuals without insurance for 2023 at 9.3% and for 2024 at 9.2%. And so there were several comments from stakeholders urging CMS to take a closer look at the uninsured rate in light of the PHE or the end of the PHE and the Medicaid redeterminations that would occur and ultimately increase the current projected uninsured percentages. So CMS addressed this topic in the final rule and also points providers to an Office of the Actuary memorandum on the certification rates of the uninsured. Ultimately, instead of increasing these uninsured rates, CMS's updated data and projections now show a large drop, and that's reflected in these final rule percentages. So after updating their estimates with the most recent data, this leaves us with a final rule rates of 7.7% in 2023 and 8.5% in 2024. The calendar year values are then converted to the payment year using a weighted average approach to get to ultimately 8.3%. So defending these percentages, CMS states that while Medicaid enrollment is expected to decrease significantly, the insured share of the population is only expected to decline from 92.3% nationwide in 2023 to 91.5% in 2024. So a very small decrease in the number of truly uninsured. CMS states that many individuals who are not disenrolled from Medicaid during the PHE already had comprehensive coverage from another source and thus remained insured when disenrolled from Medicaid. The memo also states employment and enrollment in the employee-sponsored insurance is projected to remain strong due to a very little change in the unemployment rate, and enrollment in individually purchased insurance is expected to remain robust, in part to the Inflation Reduction Act's expanded subsidies that apply through 2025 for marketplace coverage. So after running these updated percentages through the formula, factor two equals 59.29%. That's compared to the proposed rule of 65.71. And so then to get to the final UC payment amount, you then apply that factor two 59.29% uninsured rate to the 10.015 billion factor one to calculate an uncompensated care pool of 5.938 billion. That's a 774 million drop from the proposed rule and a 936 million drop from the last year's final rule. And so this 2024 UC amount is a 14% drop from last year, and that will be distributed to almost 2,400 hospitals. So as you can see from a trending perspective, the UC pool in 2014 was $9 billion, and then it steadily declined as the rate of uninsured declined in the US, or at least what was estimated to decline using, at that time, CBO data. And since the switch to some new metrics in 2018, and as a result of the changes of various factors that impact coverage decisions, under the Affordable Care Act, the rate of uninsured ticked up. 2018 and 2019 is basically flat in 2020 and 2021. And now we see in 22, 23, 24, the steady decline. It's driven primarily by the drop in the Factor 1 DSH estimate. And now there's a significant drop in Factor 2 as well. So for the actual distribution of the pool, CMS revised their formula this year and is using 3 years of audited S10 data to calculate each hospital's Factor 3. So this calculation uses the audited data from federal fiscal year 2018, 2019, and 2020. And CMS has pulled this data from the March 2023 HCRIS run. Now in terms of interim payments, CMS proposed to modify this calculation be based on an average of 19, 21, and 22 historical discharge data. They were excluding 2020 due to the pandemic. However, based on provider comments, CMS modified this in the final rule, and now will use only discharge amounts from 21 and 2022. CMS decided to exclude 2019, as they stated, in kind of including this year, may overestimate the discharge volumes in 24. Jamie, I think it's time for our next polling question.
Thanks, Jonathan. This is our third polling question. Has your organization analyzed non-charity transaction codes, for example, administrative discounts, to determine with procedural or policy changes these write-offs can be captured on a future S10? A, yes. B, no. C, don't have time or need help. Or D, not applicable. For those of you that would like a copy of today's slides, you can download them from the folder that says slide deck and handouts. We will also be sending the slides via email tomorrow, along with the recording of the webcast. Give it about 10 more seconds to get your answers in. All right, here are the results.
Okay, well, so it looks like a lot of you have done this. We run into this quite a bit. As we just covered, the pool, the UC pool of payments are shrinking. Hospitals are trying to maintain, their slice of the pie, making sure that they capture all uncompensated care costs on that worksheet S10. And one of the ways is to analyze these transaction codes, other discounts, and make sure you're capturing them, whether there needs to be policy updates or procedural things at the hospital, or even patient level that could impact what's reported on S10. So if you're not doing that, we certainly recommend looking at for other avenues to capture more costs on that worksheet S10. So kind of switching gears, we do have a few Medicare DSH updates. The first topic I want to cover is CMS's proposal to reimburse Medicare capital DSH for urban hospitals that are reclassified as rural. CMS is reversing its policy denying capital payments in response to the recent decision in the DC Court of Appeals in Toledo Hospital versus Becerra. In that case, the court ruled that CMS's rule was arbitrary because the rulemaking record failed to explain why reclassified rural hospitals should not receive capital dish payments. And so there are several commenters that asked why this change was not applied retroactively, or at least for any open or reopenable cost reports between 2007 and 2023. However, in the end, CMS's proposal and now finalized rule is on a prospective basis, effective for discharges on or after 10/1/2023. And so the last thing I'll talk about for DISH is in regards to this Section 1115 waiver rule. As part of the final rule, CMS actually finalized the previously proposed Section 1115 waiver. That original proposal was from February of this year. It was actually the third iteration of CMS attempting to restrict certain 1115 waiver days in the Medicare DISH calculation. So this rule now goes into effect for discharges on or after 10/1/23. So to be an eligible or an allowable 1115 waiver day in the Medicaid fraction, the patients must, number one, receive health insurance that covers inpatient hospital services through the waiver, or number two, must receive premium assistance that covers 100% of the premium cost of the patient. And so then that patient then uses that to purchase health insurance that covers inpatient hospital services. So there's 8 states that have 1115 waivers that include premium assistance, and I've listed those on the slide. CMS did acknowledge that one of those states, Massachusetts, offers a sliding scale assistance depending on the poverty level, and did acknowledge an increased burden, obviously for those providers in that state, to identify, which ones had full 100% coverage and which ones have partial premium assistance, which those scenarios or those patients would no longer be allowed in the DISH calculation. And also, as part of this rule, CMS explicitly excludes days for patients whose care is provided through an uncompensated care pool payment. So there's 6 states impacted by this change, and they're Florida, Kansas, Massachusetts, New Mexico, Tennessee, and Texas. And this chart just shows those impacted states where the UC pool days will no longer be allowed. And that's beginning with discharges on or after 10/1/23. So providers in these states, the impact of not including these days could be severe. Every facility in those states will see their DISH payments reduced if they've been including these days. But also many may see their 340B qualification be in jeopardy. Some cases, even their DISH qualification may be at risk. So we certainly recommend all providers in these states model how this rule will impact future DISH calculations, and begin planning for that, for this now. And so with that, I think I'll turn it back over to Eric for the rest of our presentation.
Thank you, Jonathan. Okay, so we have a few other not as big items, but still important. The first is nursing and allied health program. Hospitals that have these programs likely were hit by an adjustment related to past years. The program had overspent the Medicare Advantage add-on for 2010 through 2019. Congress stepped in and instructed them to reverse that those adjustments. The MACs have been clear that they're going to spend quite a bit of time over the next several months attempting to fix that issue now and restate the reimbursement and get those revised NPRs out. So that is now finalized policy. Also in medical education related to rural health emergency hospitals, there's only a handful of these. Last year, if you joined us, this program was introduced. These are hospitals that were critical access hospitals that have been converted to outpatient only centers with some advantages in doing so for specific types of hospitals. These hospitals can now participate in medical education programs and obtain reimbursement for that. And then there's been a change to the cost report instructions to ensure that it's calculating the cap correctly for Medicare GME affiliation agreements. So that is finalized as well. I'm going to move quickly through the quality programs, the value-based program, which a lot of these issues don't actually take effect immediately, but they have been introduced. The first is the health equity adjustment, which is a bonus for providers that have a higher than average number of patients that are dual eligible. This is something that CMS will continue to evaluate in determining to properly address those who serve an underserved patient population. They've added severe sepsis as one of the measures and made changes to the calculation for the Medicare spending per beneficiary calculation. The changes are rather big. They changed how readmissions are addressed in there. They changed the calculation and some of the the risk adjustment factors. There's new conditions that have been applied for total hip and total knee anthroplasty. There is a change to the HCAHPS, the patient surveys, that will broaden the formats that can be used to complete those. And then they codified the measures on what's going to be removed from the value-based payment program. For the inpatient quality reporting program, there's 3 new quality measures listed there. They changed the language for COVID vaccine identification within the provider to language that says that the employees are up to date on their vaccines. They've added Medicare Advantage patients to the hospital-wide all-cause mortality readmission measures. And then they removed 3 measures from reporting, 2 of which are now in the value-based purchasing program, and one that the measure is just tapped out. Okay, so I just wanted to quickly talk about the health equity stuff because we've seen this in 2 different areas now. The first to point out that safety net hospitals CMS asked the provider community to identify some of the things that they should be looking for to identify what is a safety net hospital. CMS is continuing to review the responses to that, so there is no change in policy as it related to that, but they did get quite a bit of feedback in comments. But they did introduce, as I mentioned earlier, the social determinants of health diagnosis codes. Those are the 3 listed below. When those are included on claims, that will result in a higher complication of comorbidity, meaning a higher DRG payment come out. So this is something that providers definitely need to look at to ensure that they're identifying those patients and coding them appropriately. And then we will see the health equity adjustment bonus points program, as mentioned just a couple slides ago, which will provide a bonus to the total payment score for providers that treat a high proportion of dual eligible patients. Okay, so survey, Jamie.
This is our last polling question. Has your organization ensured it is currently able to identify and code for all patients with homelessness status? Your answer options are A, yes, B, no, and C, I don't know. Once you've completed all CPE requirements, you will be able to download a PDF of your certificate from the CPE progress window. Also, at the end of the webcast, we'll be pushing a survey link. We'd appreciate any feedback you're willing to share, and we'll use the information to help develop future webcasts for you. All right, and here are your results.
Yeah, that's aligns with what we've been hearing from a number of providers. This is new. Medicaid supplemental programs have dipped their toe into these waters, but this is definitely new for Medicare and will be interesting to see as we move forward. Okay, so we have only a few minutes, and it's where we can't cover every item in here. We did try to flag those that are of importance to the most hospitals. The long-term acute hospital PPS rate is also identified here. It's a 3.3% increase with a modified change to outlier, and they've finalized the quality reporting program as it was proposed. They have changed language as it relates to and reinstated the program integrity restrictions related to physician-owned hospitals, and changed the language on 855 ownership disclosure documentation related to REITs and fund-managed hospitals. The reintroduction of the restatement of the low volume hospital payment adjustment is included here, and they have revised the enrollment application criteria for a rural emergency hospital, which I said earlier, we're still at numbers that are below 10 that are finalized there, but they're expecting that to continue to expand. And with that, we're going to close it off there. I would urge people to continue to research all the different issues that are new in this year. I think we've identified most of the majors, but if you have any questions, please reach out to us, and we can certainly help. We have a healthcare content hub listed here, which has a number of important changes and updates. And we do these webcasts often, so please sign up if you're not already signed up. But I wanted to close out by identifying our annual Executive Healthcare Conference. It will be held on November 1st through the 3rd. It has a fantastic agenda, and I encourage you to check it out and come join us. With that, I'm going to hand it back over to Jamie.
Thank you, Eric, Glenn, and Jonathan, for a great presentation today. I also want to thank the audience for being engaged and submitting your questions to help guide today's conversation. If we didn't have time to answer your question, we will follow up with you after the webcast. Also, feel free to reach out to our presenters if you have additional questions. Their contact information is in your console. There are also a number of additional resources in the upper right-hand corner of your user console that might be of interest to this audience, so definitely check those out. If you met all CPE requirements, your certificate is available to download now in the CPS progress window. A copy will also be emailed to you within 2 weeks should you have any difficulty downloading it. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in your console. Finally, here is a link to an online survey for today's presentation. We'd appreciate any feedback you'd like to share. Thank you for joining our webcast, and we hope that you'll join us again next time.